Okay, madam. Can you listen me?
Yes, sir, you are audible. Please begin.
Okay. Bismillah ar-Rahman ar-Rahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Assalamu alaikum. I welcome you all to this webinar on behalf of Pakistan Endocrine Society. Today we are discussing a very important topic that is we endocrinologists are facing, two metabolic pandemics right now. So one of it, that is the obesity right now we are discussing. So inshallah, we have got two very excellent speakers that are going to enlighten us regarding the management of this very prevalent condition all over, especially in our country. So let me introduce our speakers first. The first speaker is I'm going to introduce, although he does not need any introduction, but this is going to be Professor Ali Jawa. He's a consultant endocrinologist at the WellCare Hospital, Lahore in Karachi, and he's also the past president of Pakistan Endocrine Society. Our second distinguished speaker for today's session is Dr. Azra Rizwan. She is a consultant endocrinologist at the Aga Khan University Hospital, and she is the vice president of Pakistan Endocrine Society. We are looking forward to a very wonderful session, followed by, inshallah, a very good discussion. So I would request the first speaker, I guess, I'm not sure, but I guess from the kind of flyer, it will be Professor Ali Jawa Sahab to speak first, if I'm right. So, sir, you're going to talk first?
Sure, I can do that.
Okay, sir. So, sir, the forum is over to you.
All right. Thank you very much, Pakistan Endocrine Society, for giving me the opportunity to talk. Thank you.
Sorry. Dr. Azra Rizwan will be the first speaker, and then you will follow. Because Dr. Azra is giving the approach to the patient, so your talk would follow because you will be talking on weight management part.
Exactly.
Okay.
Yeah.
Yeah, that's what I thought. I thought maybe Dr. Ali might have had some other plans, so that's why I didn't intervene.
Okay. So, madam, you just go ahead. Madam Dr. Azra Rizwan.
Yes, let me just share my screen.
Okay.
Is my screen visible?
Yeah, it's visible.
All right, Bismillahirrahmanirrahim. Thank you all for joining in, and thank you for the introduction. So, as Dr. Yaqub said, that I'll be talking about giving you some insights on how to approach a patient with obesity. And I'll be defining obesity at the start. We'll be going over the pathogenesis, some of the diagnostic criteria, and the tools used to diagnose obesity. Then we'll be touching upon certain secondary causes of obesity and how to assess the associations and complications of the condition. So just to give everyone an overview about the gravity of the situation, there have been billions of adults living with overweight and obesity. And about 40% of adults were living with overweight and obesity in a not so old census done in 2016. And this condition is involving both adults and children alike. So a recent local survey, which involved participants from all provinces, also documented high rates of obesity in our population, both generalized obesity as well as central obesity, which is alarming. An alarming 73.1% of both males and females were, met the criteria of obesity as per WHO obesity cutoffs. So it is, it's very safe to say that obesity prevalence has reached epidemic proportions, and hence there's need for urgent lifestyle strategies and interventional strategies that the patient can adopt on a long-term basis. So obesity in simple terms is an excess of fat that imposes harm upon the body. And it is often so associated with other risk factors for cardiovascular disease, such as hypertension, high blood sugars, and high blood cholesterols. And so going over the pathogenesis, if you see at the topmost, there's a visceral adiposity. Fat is not inert tissue. There's a lot of inflammation going on in fatty tissue. And there's increased production of inflammatory markers, such as interleukin-6, TNF-alpha, C-reactive protein, and fibrinogen levels. Then some endocrine hormonal factors are there with increased production of leptin and reduction in adiponectin levels. The increased fatty acids, free fatty acids, leads to reduction in uptake of glucose through the skeletal muscle, reduced insulin output through the liver, and also decreased insulin output through the pancreas, and increased lipid production and glucose production by the liver. So all this, this interplay between inflammation, hormonal activation, and insulin resistance that leads to the metabolic syndrome, what is known as the metabolic syndrome. And that is the precursor for type 2 diabetes and premature cardiovascular disease. And what kind of triggers these inflammatory markers and hormones and these insulin resistance? It's an interplay between genetic factors, that is, what you've inherited, and then lifestyle, a lot of environmental triggers, such as high calorie diets and sedentary lifestyle, reduction in physical activity. So this is what all leads to this cascade of events, inflammation and hormonal activation that ultimately leads to the development of full-blown type 2 diabetes in subjects with overweight and obesity. So there are studies which have documented that even in the absence of other metabolic abnormalities, overweight and obese states is an independent risk factor for the development of coronary heart disease, strokes, and heart failure. So you can see at all levels of weight, when the weight increases to the overweight and obese levels, there's a marked increase in the incidence of coronary heart disease, cerebrovascular disease, and heart failure. So going over the South Asian criteria for obesity. So a normal weight in our population is a BMI that ranges between 18.5 to 23. So this is lesser than the Caucasian cutoff, as you can see, and overweight is defined as a BMI crossing 23 and less than 25. And then you have the classes of obesity when BMI crosses 25, and definitely class 3 obesity when it's more than 30. So body mass index basically is calculated as weight in kilograms divided by the height in meters squared, right? And it's a very easy, it's a very reproducible and easy to do physical marker. And it's used in population-based studies. But the problem with BMI is that it measures, both bone, muscle, and fat. Bone, as you know, the more the better. Muscle, the more the better. Fat, the less the better. So body mass index, although we do use it to measure obesity levels, it is not actually ideal. Waist circumference is actually a very good proxy marker for central obesity or visceral obesity, because that is what is very closely linked to cardiovascular disease. And Asian cutoffs, again, are much less in the Caucasian counterparts, with abdominal obesity in women defined as a waist circumference exceeding 80 centimeters, and that in men exceeding 90 centimeters. Then there are more hi-fi and advanced methods of measuring the amount of fat in the body, and that requires DEXA, X-ray absorptiometry measurements. Their bioelectrical impedance absorptiometry. There's a measurement that does that as well as hydrometry. So these are all basically not used extensively because we don't have validated cutoffs, but for research purpose, if somebody is doing a study, particularly on obesity, it's a good way of assessing fat percentage. So where waist circumference is concerned, we should know how to measure it accurately, and that is done by locating the upper hip bone at the top of the right iliac crest and placing a measuring tape in the horizontal plane around the abdomen at the level of the iliac crest, parallel to the floor. And you need to make sure the ends are not too tight, but they're snug, they're well met. And the measurement should be made at the end of normal expiration. So this is the accurate way of measuring waist circumference. As I said, it's a very important marker for central obesity, but because it's a little tedious to do in a busy clinic, it's not done very, as frequently as one should be. But if you're dealing with obese, overweight patients, it's very good to monitor the waist circumference at the start. And so you can see how your interventions objectively have been able to reduce that level of obesity. And this is the bioelectrical impedance analysis body composition monitor. And this is one of this type we have at our clinic as well. It is a method for estimating body composition, in particular body fat and muscle mass. And here a weak electric current flows through the body, and the voltage is measured in order to calculate the impedance, resistance, and reluctance of the body. And as I said, that measures the percentage amount of fat in the body. Visceral fat can be calculated as well as skeletal muscle fat. To reiterate, it's not widely used. It's an expensive equipment. Plus, cutoffs have not yet been validated amongst many studies so far, but it's something for the future that can be used, more extensively once you have more practice and more data on that. So getting on to the risk factors for obesity, when a person to you presents with, this problem of weight gain and obesity, you need to assess the level of physical activity that they're engaged in, and also their dietary habits. And from that perspective, it's very important if you can ask them to maintain a food diary, where a 24 to 48-hour food diary, where they can write down everything that they consume on a regular day over a 24, 48-hour period. And so ideally that should be sent to the clinical nutritionist, where they can calculate how many calories they're consuming at the moment, and then make modifications, realistic modifications accordingly, according to the customs that the patient is adopted, coming from. So postmenopausal status is very important, because just after menopause, the estradiol levels abruptly decline, and that can lead to excessive weight gain. So that is important to recognize, and then you can monitor therapy accordingly as well, taking this into account. And of course, very, very important, that is often missed, overlooked, is the medication that the patient may be using. There are a lot of antipsychotics, antidepressants that lead to weight gain. And of course, steroids, as you all know, homeopathic Hakimi medication. You should all make a note of what kind of medications these patients are on. And this table, actually, it's a busy site, but if you can just see the various drugs that can lead to weight gain. And these are the alternatives on the right that are suggested. So you can ask the patients, for example, if a patient is following a psychiatrist, if they can possibly switch to medication that have a lesser effect on weight gain, right? For as an antidepressant, bupropion is one of the examples that can lead to weight loss, if that the patient can be on that for depression, apart, as opposed to the other medications that may be causing weight gain. Then there are also various neuroleptic agents, anti-seizures medications. That's an important example, because young females often are on that. So you can kind of, request the neurologist that, they can be shifted to something like lamotrigine or topiramate, which causes weight loss, against those other medications that cause weight gain, if possible, if their seizure activity and level allows. Then where diabetes management is concerned, there are many regimens that can cause weight gain: insulin and sulfonylureas, the TZDs, thiazolidinediones. So our aim is to put them on medications that would ideally cause weight loss or that are weight neutral, and in which we have metformin, we have the GLP-1 agonists, the SGLT2 inhibitors, which hasn't been mentioned here, a very important agent to manage both diabetes and also will help in causing weight loss. So, and have minimal amount of drugs that can cause weight gain if needed to intensify their diabetes management. So this is just examples that you can, it's important to go through the medication and ask their other physicians also to possibly put them on medication that have the least effect on weight gain. So these are the associations of obesity. Many of them are very well known, some less well known. So that is important when a person comes to you to be screening for most of these conditions. So where cardiovascular disease, stroke, high blood pressure, and coronary artery disease is concerned, those are very well known risk factors. They need to be assessed for and appropriately managed. We'll be going over that. Sleep apnea, we can talk about daytime somnolence, and if the night, they have apneic spells. If a partner had noticed that, then the gold standard is doing a polysomnography, and our pulmonology colleagues can help in this regard. Then we have infertility as one of the associations of obesity, and a lot of patients presenting, patients presenting with irregular menses and fertility. So, and then the chronic back pain, for that we need help, sometimes help of our physiotherapists, which can really help to relieve that back pain, because without that they will not be able to mobilize themselves adequately. So, and these can be divided into metabolic, mechanical, and central nervous system manifestations. And out of these, this is very important to recognize: depression and anxiety, the psychological implications, because all your treatments that you may have to offer them, including lifestyle modification, any medication that can be inhibited, that can be adversely affected, they're compliant to that if their depression and anxiety has not been addressed appropriately by our psychologists and psychiatrists. So this actually is a very nice kind of guidelines that the Canadians have come up with, and they talk about the 5 A's, in which when you're approaching a patient with obesity, you have to taking into account the long-term implications. So you need to first ask permission to discuss weight and explore their readiness for change. So that's very important, and to have an empathetic attitude to weight gain, and not to be saying that you're not exercising enough, you're not eating the right things, to be addressing everything in a very empathetic manner, so that the patient can develop a trust, a rapport with you, and will be able to follow up on a long-term basis. Then you need to assess the health status, the weight, the complications, the blood pressure, lipid levels, and all that, advising regarding the risk of obesity and the many benefits of even modest weight loss. That is important to place realistic targets, and tell them that even if they lose 5 to 10% of their baseline weight, that has important clinical implications in improving the other risk factors for cardiovascular disease. So even if there's a 100-kilogram person weighing about 100 kilograms, if they lose 5 to 10% of the weight, go down to 95 kilograms even, they will start to reap the benefits of that. So, and then you need to agree on the best weight plan depending on their circumstances, the economic, proliferation as well, and assist them by addressing facilitators and barriers, as well as that can make weight management challenging. So we need to be assisting them, and it has to be personalized, this weight management strategy. So this is actually showing you that when there's in obese patients, if the arm circumference exceeds 32 centimeters, then the normal blood pressure that you use at the clinic may not be measuring the blood pressure accurately. It may lead to a gross overestimation of blood pressures. So you need to have an appropriate cuff size, a large cuff size for measuring blood pressure. And our targets for most individuals would be less than 130 systolic and 80 diastolic millimeters of mercury. a lot of our patients have diabetes and related complications. So, and at no point should their blood pressures exceed 140 systolic. And then you need to be monitoring that. If it's come out for the first time, you can give them home, advice to get an appropriate blood pressure measurement apparatus and to monitor blood pressures in the clinic. And also you can go for 24-hour blood pressure monitoring, Holter monitoring as well. So dysglycemia, where this is concerned, the oral glucose tolerance test, assessment of dysglycemia, that remains the gold standard. It's a bit tedious to do. It's a sickly sweet solution that a person has to consume following a fasting level, but it remains gold standard because in a good 30% of patients, a fasting sugar level can be normal. Whereas when you do this 75 grams, give them the 75 grams glucose load, it unmasks dysglycemia. So these are the normal levels: fasting less than 100 and 2 hours post-meal less than 140. Pre-diabetes is the level between 100 and 125 milligrams per deciliter. 2 hours post-meal for pre-diabetes is the level between 140, ranging between 140 to 199 milligrams per deciliter. And overt diabetes is when fasting exceeds 126 milligrams per deciliter and 2 hours post-meal exceeding 200 milligrams per deciliter. And dyslipidemia is measured by doing a fasting lipid profile, and our targets for our high-risk overweight patients is to have the LDL cholesterol definitely less than 100, ideally around 70 milligrams per deciliter. We are talking about 50% of baseline reduction as well in some guidelines. Then triglycerides, we should aim for triglyceride level less than 150 milligrams per deciliter and high HDL levels. So to talk a little bit more about metabolic associated fatty liver disease, that has been recently renamed from non-alcoholic fatty liver disease because it's basically the hepatic manifestation of the metabolic syndrome. And so in all our overweight obese patients, you should also monitor liver function tests. And why I'm asking you for albumin and platelet count also, everyone has a CBC anyway for various health reasons. Plus it will help you to calculate the fibrosis 4-score calculation. Basically, this can be fibrosis 4-score calculators can be downloaded to your laptop, to your gadgets. And it's a very easy way of calculating the risk of fibrosis that I'll be showing you in the subsequent slides. And because of that, that uses age, AST, ALT, platelet counts to define fibrosis 4 scores. A level less than 1.3 rules out fibrosis. More than 2.67 predicts fibrosis. And if your patient is in the indeterminate high probability risk, then they should be referred for a fibroscan assessment for exact quantification of liver fat using your CAP scores, which I'll be going over. The other measure is NAFL fibrosis score. That uses, addition to ALT levels, it uses BMI, albumin, presence or absence of diabetes. So the FIB-4 score is more commonly used. It's very easy to do. It's a non-invasive thing completely. You just need your platelet counts, ALT, AST levels, and the age of the patient to predict this condition. And this is how fibrosis, this is the amount of fat that is represented with your CAP scores. If there's less than 10% of liver fat on your liver, then that is read as less than 247. That's not B upon M CAP score levels. And as you go up, as the fatty liver content increases, your CAP scores, as you can see, increase as well, right? So a level more than 299 indicates more than 67% of fat in the liver. So this is very important, association of hepatic and non-alcoholic fatty liver disease and obesity. So fibroscans are something that can be used to assess, quantify the liver fat. Then you can see your interventions, whether it's lifestyle modification, whether any medications you've given, how the fat level, objectively gets better before and after the intervention. Ultrasounds basically of the liver also show you fatty liver, but that is a very broad way of assessing the liver fat. Only if the fat level is more than 30% will you be documenting fatty liver in the through ultrasound. So fibroscans are a more sophisticated and a more accurate measurement, which actually exactly quantifies the amount of fat in the liver. So where this is available, it is recommended for our obese patients. And this is the fibrosis scores, how they're documented This is, the various conditions, and we're dealing with non-alcoholic fatty liver disease or metabolic associated fatty liver disease, and a normal KPA score, fibrosis score of less than 8. That is normal. Anything above that is considered high fibrosis scores. Now, getting on to the other very important condition that our female patients present with, is the polycystic ovarian disease, in which our weight gain leads to oligoamenorrhea. There's maybe clinical biochemical evidence of hyperandrogenism. But for this, we need to exclude other abnormalities. We need to do thyroid function tests to make sure there's no hypothyroidism there leading to the weight gain. And then you need your LH-FSH estradiol measurements to make sure there's no primary ovarian insufficiency that is leading to the irregular menses. Prolactin levels, high prolactin levels, of course, can lead to amenorrhea as well. That needs to be managed differently. You obviously 17-hydroxyprogesterone measurement. This is the non-classic CAH screening is done through 17-OHP measurement, and that is the biggest mimicker of polycystic ovarian disease. So that needs to be excluded. You just need to do it once. If it's normal, you don't need to be repeating it again and again, right? And very importantly, if a patient is presenting with weight gain and is saying that they've done everything, they're being good with their diet, but there's been relentless weight gain over the previous couple of months, then hypercortisolism needs to be really looked at. And for that, I'll just give you some pictures of someone presenting with Cushing's disease, in which there's centripetal obesity, relatively thin limbs, and in normal obesity, obesity is not associated with hypercortisolism. This obesity is generalized in distribution. You will have excess weight, not just over the abdomen, but over the legs and extremities as well. But as you can see here, there's predominance of obesity centrally, and the extremities are paradoxically thin. So this can alert you to the presence of something other than just primary obesity, and you have to look for excess cortisol as being one of the reasons for the weight gain. There's a dorsocervical hump here, accumulation of dorsocervical fat in a patient who was found to have Cushing's disease. And this is a male patient who was having easy bruisability, multiple ecchymosis due to minimal trauma, and later found to have hypercortisolism as a cause for this, weight gain. So screening for hypercortisolism, first of all, you need to exclude use of exogenous steroids, and that can be done through a meticulous history. You need to ask them about oral steroid use, any inhalers they may be using, intra-articular steroids that they may have used, and also homeopathic Akimi medication that are notorious to have steroids in them. And that has to be tapered down slowly, and if possible, off. Then you have your overnight DEX suppression test. This is if you're just really want to exclude Cushing's and hypercortisolism. This is a very simple test to do, in which you give 1 milligram of dexamethasone at 11 p.m. at the night and measure next day 8 a.m. cortisol level. And the level should be less than 1.8 micrograms per deciliter. If you have a high index of suspicion, then you need to do your 24-hour urine cortisone and urine creatinine as well to assess for adequacy of collection. And we don't have the midnight salivary cortisol here, but that is a very specific test. When it does become available, it's very, very important and specific, since it has a high specificity and sensitivity for detecting hypercortisolism, right? So this is something that needs to be kept in mind when someone is presenting with weight gain, has an unusual distribution of fat, and is saying they're doing everything, but there's still been a lot of weight gain over the previous months. Then Cushing is something that you need to exclude. So once you've done all that, excluded your secondary causes, then in the right clinical context, this is a way of staging obesity. It's known as the King's Obesity Staging Score. This is how normal health is assessed, in which you're looking at the airways, body mass index, cardiovascular disease risk, as done through the calculators that we have, Framingham scores that we have available. We can easily download it. Also, diabetes, economic factors, and then gonadal health, body image. Then when stage 1 describes someone who's at risk of disease, in which where airways are concerned, we talked about sleep apnea, that starts happening. And then there's impaired fasting glycemia, PCOS, low mood. Quality of life basically gets worse and worse as the stage advances. And you have, in the advanced disease, you have established cor pulmonale because of right heart failure, untreated obesity, and treated sleep apnea, and there's heart failure, uncontrolled type 2 diabetes, unemployment due to obesity, and severe depression. So this is how they're scoring the physical markers of cardiovascular disease and respiratory health, as well as body image, quality of life factors. So now the effect of weight loss on complications, that is very important. As I said at the start, when you're talking to the patient, telling them that even to 5 to 10%, as it is 5 to 10% of weight loss from baseline, can lead to a lot of health implications, positive implications on health. And that includes prevention of type 2 diabetes, some cases early forms of metabolic fatty liver disease, and PCOS, dyslipidemia. Greater amounts of weight loss are needed when there's established cardiovascular disease and established metabolic associated steatohepatitis and new osteoarthritis. And again, in even greater amount, more than 15% of baseline fat loss is required for achieving type 2 diabetes remission and reversing cardiovascular mortality, as well as heart failure. And Dr. Ali Jawa will be talking about ways of achieving that as well. So the take-home messages here is that it's high time that obesity is recognized as a chronic disease in the same way as we recognize other chronic disease. Assessment of lifestyle measures and advice on modification, appropriate advice on modification is kind of very imperative in all cases. You need to do a good history and physical examination, as is for any other medical condition, and also a medication list, including a thorough review of the medications that may be responsible for this excess fat, and the appropriate clinical context, exclusion of secondary causes, such as thyroid disorder, hypercortisolism is important. And then assessment of comorbidities, an appropriate referral, a multidisciplinary approach is essential if you are to manage the comorbidities in a timely fashion and in an efficient way. So that would be all from me, and I'll be glad to hand it over to Dr. Ali Jawa for his talk on how to manage this condition.
Thank you, sir, very much, Dr. Azhar for an amazing talk. I think you set the ground too well for me, and I would love to share the thoughts that I have, and I am going to share my screen in just 1 minute. All right. Is everybody able to see the slides?
Yes, sir.
All
We're
right,
able to see,
great.
sir.
Excellent. All right. So basically, obesity, as you have understood very in a very detailed fashion right now, you have to exclude the other causes. And once you have excluded, there's no secondary cause. Now you need to deal with it. And obesity itself there are certain principles. Many of these principles are kind of easily skipped over, jumped over, or ignored, but I feel that they need a little bit more attention. So I'll try to have a balanced talk on the three things like lifestyle, pharmacological, and surgical treatment. This is then something you must have realized I read the newspaper word to word, maybe even the small fine print. This was in the corner of the letter to the editor to the Dawn. It was published the Wednesday, the 28th of February. And it was so simple, and it kind of spot on for me that whenever we are happy, we are trying to eat something that is sweet. And it's sweet is not something like a little sweet. It's really sweet, and it's really rich. And it is, if it's not that sweet, we say, you know what, maza nahi aaya. On the other hand, when we go to see somebody who's sick, we take fruit. We take quinoa, we take bananas, we take other apples. Apples bring up the blood, so your blood becomes, hemoglobin goes up. These are all the thoughts that people come. So we only eat healthy when we are sick, but we eat food that makes us sick when we are healthy. So there is something wrong here. So why do we manage obesity? To improve health. We want to prevent diabetes and other complications. And if there is a patient who has already suffered, we want to make it less likely that their complications are manifesting or progressing. So in general, if the patient who is overweight loses about 10% or more of their overall body weight, they improve their complications. Now, Dr. Azra's talked the point of the weight loss, something that I just is kind of was going in the back of my mind, what Dr. Osama Hamdi in the ICE meeting mentioned. It's not only the quantity, it's the quality of the weight loss that matters as well. So if you're losing fat, you're also losing muscle. It's not a win-win. It is someone, you win something and you're losing something. The muscle is important for the general health. And we tend to not realize that when the weight loss regimen is incorporated, we need to make sure that the lifestyle is modified so that we keep the muscle, maintain the muscle, and don't let the muscle loss manifest. So the lifestyle is just to improve health. That's the whole point of that. But it's more than just LSM. It's something that we need to look into this thing. And this review was a fantastic treat for me by Usitpa et al., in which it kind of summarized that they did a retrospective review as well as Cochrane analysis of the database. And they said that we need to ask certain questions, that what are the factors that help reduce the risk of diabetes? And they found some good articles and some conclusions. They said those who have impaired fasting glucose, the risk of diabetes is 89% lower in those people who are able to lose weight and are able to sustain the weight loss of at least 5% over 3 years. 5%, you get these results, that's really amazing. Same thing, type 2 diabetes, average weight loss of 9 kg. They already have diabetes, they lose 9 kg. 46% of them go into remission versus 4% of the controls. So this means that, okay, quality is there, but weight reduction standalone also has its advantages. Now, another way they looked at it, what kind of foods have a positive correlation and in developing diabetes, and negative correlation, meaning that if you consume them, the chances of developing diabetes are reduced. Processed and unprocessed red meat, white rice, sugar sweetened beverages. This has been highlighted that if you are using more and more, the patients who are using it, they are more likely to develop diabetes. Heme iron, glycemic index, and glycemic load. That is also very interesting because the amount of carbohydrates we take at a time also matters. And the whole grain and dietary fiber is not supposed to be here, it's supposed to be on the other side. So this does not increase the risk, at least reduce the risk. Things that have been correlated with lower risk of diabetes, green leafy vegetable, no surprise there. Dairy products, whole grains, coffee, berries, grape, yogurt, and nuts. They only found a correlation with women. I don't know why they have a hypothesis, but it's just an interesting thing. And legumes, and diet that is rich in magnesium and vitamin D. Dietary patterns also matter. A Western dietary pattern is associated with increased risk of developing diabetes. And there's no surprise there either, because we have seen the obesity epidemic in the West, and we are followed them blindly, and that's what we're seeing day in, day out. Skipping breakfast and snacking, there has been some correlation that has been associated, but it's not very strong. On the other hand, if the people who are trying to reduce their diabetes, they use a plant-based dietary pattern like Mediterranean diet, which is rich in olive oil, and have plant-based DASH diet, which has more fruits and more vegetables. And the vegetarian dietary patterns, they are associated with less development of diabetes. Okay, now say, for example, the person does not lose weight and does not do physical activity. Does the diet have a role? Yes. Even if somebody does not actively lose weight on a diet and they are not physically active, Mediterranean diet that is enriched in nuts and extra virgin oil has been associated with better diabetes risk reduction, even if they don't lose weight and they are not physically active. On the other hand, another very interesting thing, also a negative correlation. Now, if you watch your diet, you lose weight, and you also perform physical activity, the three of them together in the form of lower saturated fat, a diet that's rich in vegetable, fruit, and whole grain, a Mediterranean diet, has been associated with decreasing the risk for diabetes. So the overarching theme seems to be that a good diet, irrespective of other efforts, helps, but other efforts like physical activity and weight loss contributes. Now, physical activity without weight loss or dietary changes, somebody exercises, they complain, doc, I'm not able to lose weight. I have been doing a lot of physical activity. I go to the gym, I do yoga, I meditate, all these things. You need to reassure them. Even if they are pre-diabetic, they have insulin glucose intolerance, 47% reduction or development of diabetes. And if they don't have the other one also, the IGT, 50% in a finished diabetes study. These are without weight loss or dietary changes. Now, physical activity with an energy-reduced Mediterranean type diet and exercise promotion, in metabolic syndrome, they lost 3.2 versus 0.7 kg, and they had an improvement in glucose metabolism and lipid profile. Now we come to medicines. Medicines seem to be an easy thing. Doc, give me a medicine. I need to lose weight. And sometimes easier because you have to go through the whole thing and you need to have a very strong correlation with the nutritionist. We tend to have a tendency to prescribe medicine, but the medicine works if there is lifestyle changes as well. And in general, the pharmacological therapy is able to give you a weight loss more than 10% in most of the 2/3 of the clinical trial participants. And the cardiovascular benefits, there and they are available, and various products have different benefits. So these are the generally used pharmacological agents. Semaglutide is a hotcake these days. Liraglutide is used as well. We are looking towards getting semaglutide tablets in Pakistan very soon as well. Tirzepatide is being used by the name of Mounjaro in the rest of the world. And the usual bupropion, topiramate, and orlistat are already there. I would like to talk a little bit about tirzepatide because it is a novel mechanism it has. It's GLP-1 and GIP receptor co-agonist. So it decreases appetite. Both of them do that. Both of them increase insulin secretion. Both of them delay stomach emptying. And also they have GLP-1 has lipolysis, and cardioprotection has been documented for the heart with the GLP-1. Now, you would expect this to work better than the typical GLP-1, and you would not be wrong in that. And I will show you that in the slide, in the next slide. These are the various benefits and effects on the various body organs. The weight loss that you see is 5.4 to 12.9 kg weight loss. That is about more than 10% weight loss in 20 to 69% of people with type 2 diabetes. So there were two trials for tirzepatide in people who had type 2 diabetes, as well as the SURMOUNT trial, which was with those people who were obese but not diabetic yet. In this trial, in the SURPASS trial, they used 5 to 15 milligram tirzepatide once a week over 104 weeks. They were able to reduce the A1C from 1.87 to 3.02%. Body weight decreased from 5.4 to 12.9 kg, and multiple cardiovascular risk benefits were improved. Tirzepatide was better than placebo, as well as other medication like semaglutide, dulaglutide, degludec, and glargine. SURMOUNT-1 trial in obese without diabetes, there was a reduction of body weight of 16% to 22.4%. Now, you must have noticed something very interesting. People with diabetes tend to lose less weight with the same molecule as compared to those who are obese without diabetes. This has been noted in pretty much every modern anti-obesity medication injectables. And this is an interesting observation. Diabetics don't lose as much weight with the same molecule as compared to those who are not diabetic and obese and the same drug is used. So this is a little bit of simplification that lifestyle can give you a weight loss of 5 to 10%, semaglutide 15%, tirzepatide up to 20.9%, body weight reduction. There are ranges, but this is kind of an oversimplified slide. And this is a little bit detail about it, about the various weight losses tirzepatide compared to in the DPP trial, look ahead trial, semaglutide 2.4 and semaglutide 2.4 in the step 5, 104 weeks. And it did seem to exceed all of these in weight loss categorization. Bariatric surgery is a durable weight and somewhat irreversible. You can do a reversal, technically speaking, but it is a little difficult to do it, and there are complications along with it. There are various ways gastric banding is out there, as well as Roux-en-Y surgery. The durable base around 25% is rapid, sustained improvement in the complication of the obesity. Now, the rapid is kind of, it's a red flag because a too rapid control without a way to keep the muscle on, it's a big problem. And that's what a lot of patients tend to have a problem with that. Other thing is that there is a lot of malabsorptions which need to be looked into. So diabetes remission is with very low calorie diet and bariatric surgery. They're the only two things they have the potential to do that. Other can do it, but not very strong data out there. So bariatric surgery has not been compared with the modern new generation anti-obesity drugs. All right, so that's my last slide. The take-home message, the 3 pillars: lifestyle modification, pharmacological therapy, and surgery. Diet quantity, quality, pattern of eating, as well as physical activity definitely matters. Newer anti-obesity drugs are more efficacious compared to lifestyle modification, but when you couple them together, the benefits do add up. Bariatric surgery has durable and sustained benefits. It's irreversible, has certain complications, but if the risk of not treating diabetes compared to the bariatric surgery is compared, and bariatric surgery is much more effective in remission in those who are very obese and are at risk of comorbid complications. Thank you very much for your time.
Thank you, sir, for the insights, and we were very grateful to Dr. Azra and Dr. Ali Jawad Sahab for such a valuable insight regarding the obesity, the complication, and of course the management and so much details. Now the forum is, I think, open. If anybody is going to ask some questions, so our speakers are available to answer. Okay.
In the chat box, somebody wrote about how the overnight DEX suppression tests. So I wrote it, I think the answer in the chat box, but I'll just go over it again, that you give 1 milligram of dexamethasone at 11 p.m. and then you check a cortisol level the next morning at 8 to 9 in the morning, fasting condition. And the level should be, normal cutoff is less than 1.8 micrograms per deciliter. So basically, dexamethasone tablet is available in, one tablet is 0.5 milligrams strength. So you give 2 of these at 11 p.m. and measure the 8 a.m. cortisol the next morning. That's how it's done.
And there is another question in the chat box about the SGLT2 and the non-diabetic patients for the weight loss. So if Dr. Ali Jawad, please comment on this.
For non-diabetics, we have to look at it can be helpful in heart failure patients because it tends to help them in that, but not for the sake of non-diabetics. I don't think I would recommend that at this time.
Okay, thank you, sir. And I think there are some easy questions as well, like the anti-obesity medication available in Pakistan. So already, I think Dr. Ali Jawad Saab has, shown all these in very much details.
What was the question?
Yeah,
Yes,
somebody's asking about the anti-obesity medication available in Pakistan. So I think, sir, you have mentioned all of them.
Yeah, semaglutide tablets should be coming very soon. Semaglutide
Exactly.
injection is available in Pakistan. Liraglutide is available in Pakistan. Tirzepatide, which is Monjaro, is not available in Pakistan. It is available worldwide. So I felt it was a novel mechanism. I need to discuss it. Many of the patients may be living in other countries like Canada and USA, and they may be coming to stay. So if you are familiar with it, you know what the effects are. And when it comes, you should be able to prescribe it with more confidence.
And sir, one participant is asking about the fasting, how fasting helps in obesity. He wants, what is the impact of fasting on, weight loss?
Whenever their body is fasted, it puts a stress and it helps reduce the free radicals and makes the inflammation go down a little bit. So it is one of the recognized ways for weight loss, um, but it's usually used in the short term. You need to have a very close relationship with the patient if you are prescribing them like intermittent fasting, because many of the medications may not be conducive to it. If they are, what medication they're taking, what lifestyle they have, are they able to maintain enough protein in their diet? If you look at the data that I presented, there is a very strong preponderance of emphasis towards whole grain unprocessed food, and also somewhat protein needs to be maintained, especially if somebody is undergoing weight loss. So if that can be balanced, you can do it, but it's just one of the many tools you have. You can do that.
Thank you, sir.
It's 2.4 milligram is, or up to 3, you can give it semaglutide injectable for weight loss. But you need to discuss it with the patients first, whether they want to go for a biological treatment, or do you prep, because lifestyle modifications have other benefits which semaglutide will not have. So you need to have a frank and open discussion about the cost as well as the risk versus benefit of taking semaglutide for just weight loss.
And I think, sir, one last question we take, after which we will conclude the session. So a participant is asking about the participant is asking that GLP-1 agonists are very much expensive in our country. So what about should we go for the orlistat or bupropion? I'm not so sure whether bupropion is available in Pakistan or not, but I think if your comments on the orlistat.
Bupropion is available in Pakistan.
Okay.
I think if I'm not wrong, I'll have to look it up, but I can share that with you. It is available in Pakistan. Orlistat has some caveats. People can easily overcome it, the effects, because if they don't take it 3 times a day, they will not have the benefit fully. And if you take it and you take fats, there is oily diarrhea, and the weight loss is not that robust. So bupropion is used for smoking cessation as well, and that's why it is also used for weight loss. Topiramate is also a good choice. Both are available. I won't name the brand names because it is unethical for me to be saying a certain brand name, but I prescribe them very regularly. But you need to talk to the patient so they know that what are the advantages. If you have a smoker, they may get a double advantage. They have a weight loss because after stopping smoking, many people gain weight. So bupropion is also a good smoking cessation tool as well as for weight loss.
Thank you, sir. We're so grateful to Professor Ali Jawad Sahib and Azra Rizwan Sahiba, who blessed us on this occasion with your insight, very much informative session. We are very grateful to all the participants who participated in the session. So with this, we conclude this session, and inshallah, we will meet in another webinar with another, inshallah, wonderful topic from the Pakistan Bhutan Society. So thank you very much.
Thank you all. Assalamu alaikum.